Live. Okay, we have got a rather interesting show for tonight. I will say it that way. We have a very interesting show. So while I'm giving you guys a couple of minutes to jump on board, I am just going to kind of tidy up some things here so that you guys, I know what I'm sharing here because I'll be sharing some very interesting pictures this evening. So I think we are good and we are ready to go. Okay, so we're going to wait for you guys to jump on board. And for those of you, sorry, adjusting all the tech, all that kind of fun stuff. For those of you who are watching the replay, thank you again for watching. And thank you for those of you who've been putting your comments in there for the replay. So put replay into that comment section. Let me know that you're there. Hashtag live. There's Captain right there, man. Captain, good to see you, man. It's been a while. So I'm so excited that you're here tonight because I'll be sounding off tonight, Captain. So yeah, I'll be sounding off tonight. So you guys can see my little disclaimer. Hey there, Andrea. There's my resident occupational therapist. So I'm so excited this weekend. Andrea and I are going to be attending an amazing continuing education course for amputees given by Dr. Scott Love up in the University of St. Augustine. So I'm just so excited about that course because I'm a nerd and I love to learn and I love taking these courses. Let's see. We got Eric drinking his Fiji water. We got Val. Chuck is here. I keep saying Val, but it's Chuck coming in from Wyoming. That's right, Bailiff. That's right, Captain. Okay, everybody who has a COSITALKS mug, raise your mug high and cheers. Let's get this evening started off right. Holy smokes, Marianne, 16 degrees in South Dakota. That is just, that's just not legal. That's just bad. Brian, what's going on? You got your Bustelo right there? Good. I know you never disappoint me with that. We got Kay from the very cold Alaskan night drinking hot chocolate, which I think you're going to need it. If South Dakota is in the 16 degrees, I can't imagine where you're at. We got Kimberly on board. Thank you for joining us this evening. We've already got a very nice group on board, guys. So thank you for joining in. We got Jennifer on board. Guys, can you just tell me if you received that text message I sent to you about 10 minutes ago? I think I timed it kind of right. If you got my text message, can you just put that into the comment section? I want to know how it's working out with this new texting service that I'm using. For those of you who don't know what I'm talking about, I'm going to put that into the comment section right now. I'm trying to find my own number because I still don't have it memorized. So guys, not too long ago, I started a texting service and it's basically for me to be able to communicate with you and for you also to be able to send me messages. Okay, so if you are interested in being in this texting thread, if you are interested in this thread, all you have to do is text COSITALKS, all caps, one word, to that number. I promise I'm not spamming you with a bunch of stuff. I'm not selling your number. It's basically just to give you a heads up. I'm about ready to go live, and this is what we're doing tonight. Okay, good. So Chuck got it. Let's see. Kay got it. Marianne got it. Andrea got it. Okay, good. Thank you, guys. All right, guys, we're going to go ahead and get started because this is, oops, I keep pressing all the wrong buttons here. All right. So for those of you joining me for the first time this evening, welcome. Hey, Pastor David. My name is Cosi Belloso. I'm a physical therapist amputee specialist here in Tampa, Florida. I've been a PT now for a little over 20 years, guys. December is the month that I officially got my license, 20 years, so 2002. Huh, that's been a long time being a PT and I've loved it. So guys, I do have to say this evening, I will be sharing some pictures tonight. Some of them are kind of graphic. It's basically pictures of a wound, of a non-healing wound. And it's kind of gnarly looking. So it's some pretty graphic pictures. I know some folks, not their style, not their thing. And I promise you, I will give you advance notice when I'm getting ready to put the picture on the screen. I do want to let you know that I have permission from the person to use this picture, and I removed anything that could possibly identify this individual. So we are observing privacy. We are observing everything there. So there's my little disclaimer there. Hey, Linda, we got Johnny. Johnny, I'm so glad you're here. Tom, what's going on? So you got the text as well. So guys, I kind of posted in the text message and also posted in the social groups about this case that I encountered last week. And I know I was a little mysterious about it. But you know, it was a case that was brought to my attention last week. And I was kind of chewing it around in my head going, do I share this? Do I not share this? Because this is something that I've encountered a lot. So I was just like, you know what? Let's just bring it out in the open. Let's just talk about this particular case. Hey, Denise, and with this case, there's a lot of little lessons to be learned, and hopefully it might resound with some of you because I know I see this problem on the Facebook support groups. I see it a lot, okay? And it has to do with wound care. So here's what happened. Last week, I get a phone call from a physical therapist that I know and love. Now, this particular physical therapist, we are not mentioning names. We're not going to mention anything like that. She's only been in practice for maybe 2 years, I think, just 2 years. So she's a relatively new physical therapist, right? New to the field, new to being a clinician, right? She's doing an amazing job, guys. I met her back when she was still a student. Very interested, very motivated, wants to help the limb loss community, right? So she has taken it upon herself to get education, get informed, get training, right? So every once in a while, she'll text me a case and say, "Hey, I'm struggling with this case right here. What do I do?" And we talk through it, and it's great. That's what so many people did for me when I was in those first years as a therapist, and it's I love being able to do that and work with other therapists, right? So she sends me a picture and she just says, "I have this patient who came in. She had her amputation a few months back and a below the knee amputation. And in the process, shortly after the surgery, her wound dehisced, meaning the wound came open. The surgical wound did not heal properly, right?" And that happens. Sometimes it happens because there's too much strain on the wound itself and it just starts to open up. A lot of times it's because somebody has a fall, unfortunately, and will hurt that wound, and that wound will start to open, right? So this wound started opening shortly after the surgery. So it's been about 2 or 3 months with this open wound. And this particular individual went to her prosthetist because she was told, "You're ready to go get your prosthesis." So she went to the prosthetist and she showed the prosthetist this wound and said, "What do I do?" And she was told, "It's okay. I've seen worse. We've had people walking on worse." And apparently, I think in this, and this is just a very general description of what happened, this individual went to her doctor and was told something similar. And I don't know if it was the doctor or the prosthetist, but they basically told her, "Just put some Neosporin on it." Okay. So this person was fit for a socket. And as you can imagine, she had been having a lot of pain using the socket. And she was using the socket because she was told that she could walk and try using the socket with this wound. At no point did anybody recommend going to wound care. At no point did anybody say to her anything about this, right? So she comes to see this physical therapist, and this physical therapist sees this and goes, "This is not right." Right? Now, this particular physical therapist does not have wound care experience, but she's a trained clinician to understand that that was a non-healing wound, non-healing ulcer, and it was not good. Right? So she got permission from the patient. The patient allowed me to see the pictures, and we did a phone consultation. Right. And it turns out that this woman is a very active individual. Her current profession requires a lot of physical activity. She thankfully did not have any other comorbidities, because otherwise this wound would have turned very ugly. Yeah. No, Andrea, I am not making this up. Good. I am seeing the right reactions here, guys. Good. Okay. Now, there are so many things wrong with this situation, right, guys? Right? First of all, I want to take the time to applaud the physical therapist. And guys, let me take another step back. I've seen this situation happen with different clinicians, meaning I've seen PTs make this mistake. I've seen doctors make this mistake. I've seen prosthetists make this mistake. I am not trying to single out the prosthetists in this scenario. It just happens that in this scenario, the prosthetist is the one who didn't do good. Right? But I do want to applaud the physical therapist, number one, for being such a young therapist, right? And recognizing a situation that is no bueno. And then on top of that, understanding that she needed to go and find help for this patient and that she was not able to provide that help at that moment. Okay. That's the sign of a really good clinician, guys. A lot of times, and I myself, when I was a young therapist, I knew that there were certain things I didn't know, right? But sometimes you're afraid to ask. You're afraid to tell people, "I don't know," right? Because you have this license in your hand and people have been telling you, you should know, and you shouldn't. If you're a clinician, especially a physical therapist, and I'll speak for PTs, if you're a physical therapist with less than 5 years of experience under your belt, okay, you should be consulting with senior PTs. You should be reaching out for help when you have a case that is outside of your scope. So the physical therapist acted appropriately. She knew something was wrong here. She knew that this was not supposed to be happening, right? She didn't know what the solution was, but she knew she needed to find help. Okay. So guys, at this point in time, and I promised you guys, I know guys, it's a bit of a mess, right? So what kills me, number one, is the prosthetist said, oh, I've seen worse, and we've walked people with worse wounds. Now, when you see the picture of this wound, it's an intense wound. I'm not going to lie. It's a pretty gnarly wound, right? Have I seen worse? Oh yeah, I've seen a lot worse. Okay. I worked wound care. That was one of my things that I loved to do when I worked in burn trauma, amputee care, and wound care, right? And in amputee care, I did a lot of wound care, but I did wound care in a lot of different areas. I've seen a lot worse wounds, okay? But when I see this wound, I don't think, that's nothing. No, I think that's a non-healing ulcer. That's a non-healing ulcer, and that needs to be taken care of. So guys, I am going to post the picture of this wound. So those of you who are not into seeing pictures of wounds, go ahead and exit for a few minutes. I'm gonna share this picture. If you want to just go into another tab and you can still hear me talking and you don't necessarily have to look at the picture, but I am going to share the picture now. Okay, guys? All right, here we go. As soon as I get it up, of course. All right. So guys, this first picture, and we're going to talk a little bit about the picture so you guys can understand what's going on. Here it goes. Okay, Denise is out. All right, she's like exit stage left. All right, guys, here it goes. Okay. So when you see this picture, okay, I'm going to talk a little bit about what we see from a therapy standpoint. Okay, this is obviously non-healing. Okay, and you can see it's right on the suture line. You can see that this is where the sutures came apart and this wound started to collect this tissue, right? So that black tissue that you see there, we call it black eschar. Okay, that's just a fancy word for necrotic dead tissue. Okay, couple of problems that I see here, couple of things that for me make my red flag go off. Number one, we don't know what's going on underneath that wound. Okay, and that's probably our biggest obstacle right now, is knowing how deep does that wound go. Okay, a lot of times when we have that tissue sitting on top, right, it's adhered, it is stuck. So we don't know underneath what's going on. Okay, I'm going to stop sharing that picture. Okay. Okay. Hey, Ray. Yes, eschar. It's just a fancy word for black, necrotic, or dead tissue, right? It's just, and guys, this is something we see a lot, okay? So the wound, you know, it's a decent sized wound. So let's talk a little bit about the wound side. I don't talk enough about wound care, guys, and I love wound care. I know that sounds really weird. I love wound care. I loved it when I worked in the wound care clinic. I loved it when I did it in my internships and my rotations. I did a lot of wound care when I did burn trauma. It's something that exactly, Ernest, possible tunneling. Now, in the case of this particular individual, and again, I'm playing Monday morning quarterback. This individual is going to be followed by a certified wound care clinic, thank goodness, right? But I'm willing to bet that because this individual does not have diabetes, does not have any of these other disorders, that is going to be a slightly deep wound bed, but hopefully no actual tunneling. Okay, so what happens, guys, when we have these wounds, right? Our body produces an inflammatory response, right? It basically says, there is a wound, whether it's a little paper cut or a big giant wound, but it says there's a wound. We need to send our soldiers in, the immune system. We need to send all these fun things into that wound to start healing it. And it creates an inflammatory response, right? And that's actually a good thing. It actually brings the good stuff to that wound to start healing it. Sometimes, right? Sometimes things do not go well, right? And we start seeing this kind of tissue forming in it. Eschar tissue. Sometimes we see something called yellow slough, and we're going to put another picture up shortly to show that. Okay, so what happens is the wound is supposed to be healing from the inside out, right? When we see a healthy wound, we call it red beefy. And I know that sounds like, oh, Cosi, really? Yeah, that's why I didn't get a whole lot of dates back in college, guys, right? But we see a red beefy wound. Red signifies that there's good circulation going in there. It signifies that there's no dead necrotic tissue. And then we see the wound slowly budding in and healing from the inside out. So when you have that black tissue just sitting on that wound, it's stuck. It's not allowing that granulation. It's not allowing that healthy tissue to granulate in and fill in, right? And then worse, underneath it, that's where you can start to see some infections form, okay? Right? So I'm seeing here Ernesto right here is he sounds like a wound care guy. He says, I come from the Hubbard tank area. Man, I love me some Hubbard tanks, Ernest. Yes, Houston, we do have a problem. We do have a problem. Yeah, Andrea's spot on. All my clinicians here are chiming in with all the right stuff. She says, beefy red means ready to heal, right? That wound is not ready to heal. And that's what we call a non-healing ulcer. And that wound has been looking like that on that patient for the past month. It has not changed. It hasn't gotten any smaller. So that thing was just potentially going to stay like that. And no amount of Neosporin, you could spray it with Windex and you would have had the same effect as putting Neosporin. Right? I heard that and I was just like, oh, dear heavens, give me patience, right? So yeah, yes. And Ernest is right. Vascular meat is good. Yes. Okay. So beefy red tissue, good. Black eschar, yucky tissue, bad. Okay. So let's talk a little bit about the wound care stuff because, that's the stuff I like, right? So again, I'm not seeing that picture right in front of me, but automatically this person needs something called an enzymatic debridement, meaning there's lots of topical potions and lotions, and I'm honestly probably out of date because it's been a few years since I've worked with this kind of stuff, but we have certain creams and medications that we can put on that wound to help eat away at all that gross tissue. And it literally will eat away at that tissue. And then the physical therapist or the wound care nurse, okay, depending on who's on the team, then we go in and with either a scalpel or with dry tissue, and we carefully scrape all that junk off. Okay, so basically you need something to soften all that crap up and eat through it, and then to mechanically, what we call mechanical debridement. And you can do mechanical debridement a wide variety of different ways. There are certain dressings you can put on. You can do the mechanical, that's what I used to do all the time, and just start taking all that junk off. And absolutely, Andrea, the edges right there are all inflamed and red. So that is not a happy wound. It's not. Okay, it's not a happy wound. Ernest says, I haven't had wound care since the 90s. And honestly, guys, those of us who've done wound care, it's like riding a bicycle. We understand the mechanics of wound care. We may not be up to date on all the different medications that are used, but we can all understand that that is a wound, that is a non-healing ulcer. We need to get that tissue, that black eschar, out of that wound and allow for a healthy granulating bed of tissue to be there, right? Charlie, that's a very good question. Wouldn't they put a leg with a wound in a whirlpool? Yes and no. In some cases, a lot of times it depends on the facility. So for example, the facility where I trained, the physical therapy department had those whirlpools. We call them the Hubbard tanks. And it's exactly that. It's like a big old hot tub, medical grade hot tub, right? And you put the patient wound in there and you let that water soften up all that tissue, right? So, depending on the wound, depending on the doctor, depending on the availability of the wound of the Hubbard tank. Yeah. And me personally, I liked Hubbard tanks because for me, I'm just like, dude, it really softens up everything and it allows me to get in there and get that stuff out. And I had some really wonderful success stories with patients clearing up some pretty gnarly wounds using the whirlpool. But more importantly than the whirlpool is what's getting put onto that wound, right? And that's the part where I do actually have a wound care specialist. I need to get Heather back on this show again. She hasn't been on the show in a couple of years, so we got to get her back on the show, right? To talk about some of the things that they use. And again, enzymatic debridement, that's a big one where it's a special lotion that goes on there and it interacts with that tissue and it starts breaking down that tissue, right? And mechanical debridement. I know, guys, and I apologize if this is a trigger for some of you, because I know many of you probably went through some pretty terrible wound care experiences yourself that may have led to your amputation or even after your amputation. Brian says 4 years of MRSA debridement history, and that's the short of it. Yeah. Yeah, guys, I've seen people who've had some wounds for such a long period of time. And again, much like other very specialized things in healthcare, when you have a wound, you need the wound care expert. And obviously in this particular situation, there was not a wound care expert. But here's what makes me upset. Here's what makes me, and this is the part where I'm going to sound off a little bit, because this is a situation that I have seen on the Facebook support pages. This is the situation I've seen in one of the clinics here in Tampa. I'm not going to name the clinic. It's one of the clinics in the Tampa, St. Petersburg area, where I had the same situation with two of my patients. They went to see the prosthetist. They had an open wound that was weeping, that was a mess. And the prosthetist went ahead and casted the person. Did not refer to wound care, didn't even refer them to me, nothing. And I got the patient much later on down the line. Okay. I've had several of you sometimes send me pictures. And the first thing I've told at least 2 or 3 of you is get yourself to a wound care clinic. And I found a wound care clinic in your area and you got it taken care of like that. Okay. So first things first, anybody who has a wound that looks like that, anybody who has a wound that is more than a blister. Okay. And I mean this mainly because we have a lot of folks who are diabetics. We have a lot of folks who have history of high blood pressure and vascular disease and arterial and venous disease, right? These are the folks that are going to get into trouble with these ulcers. But even like this young woman, the picture I just showed, she has none of these things, right? And she has this wound sitting on there. So when you have a wound that is not healing, it can be this size, it can be that size. But if it's a wound that is not healing, you need to go see your doctor. Okay. Now, why am I getting excited about a tiny little wound that's this big? Because it can tunnel. And what do I mean by tunneling? I mean exactly that. It's a tunnel that can form like a little snake in your soft tissue. Okay. Because I've had a lot of people post pictures online where they're just like, it's just a tiny pea-sized wound. I've had it forever, but it's just sitting there. Guys, that's not okay. And that's not normal. Okay. How many of you guys have seen that kind of a post in one of your Facebook support groups? Can you put that into the comment section right there for me? Oh yeah, Patricia, that needs to be debrided. It needs a lot of stuff, that wound right there. And here's the kicker. The good thing is that we have this, this woman is going to be, she has an appointment with the wound care clinic, and the physical therapist is providing just basic wound care stuff that she was recommended by the wound care clinic. So this woman's going to be seen very shortly by the wound care clinic, and that wound is going to heal very quickly. And that's the part that makes you go, because this poor woman, has been months with this wound when it could have been healed. Right? And I know it's going to be healed. So how many of you have seen a situation like this on one of your support groups? Of people posting a picture of their wounds and saying, what should I do with this? Or people posting saying, oh, my clinician told me it's nothing to worry about. And you're sitting there going, oh, dear heavens, right? So the first step, guys, is get yourself to the doctor, okay? And in some cases, if you're starting to display symptoms of fever, intense pain, you might need to go to the ER because that wound might be infected. Right? We did a whole show on cellulitis and osteomyelitis way back when. So that's a great show right there for you guys to reference about some of these things. But a wound that's not healing is not acceptable. Okay. I'm not talking about the blisters or the heat rashes that you guys get from wearing sockets and, you have to take care of it and it starts to heal. I'm talking about stuff that is not healing. Okay. You need to get it seen. And I'd much rather have somebody go to a wound care doctor and the doctor say, okay, it's not bad. Just do this and this on your own and you'll be fine. Okay. Now, occasionally you'll run into like this situation, the doctor who was not aware that this required more extensive services. I don't know what went on there. Don't have all the details there. Okay. But as a patient, guys, you guys have the right to look up a wound care clinic, and it's a Google search away. That's what I do. When one of you guys has come to me and said, what do I do? I Google search wound care clinic in your area, and that's how I find it. And thankfully, there's a lot of them around. Some of them are freestanding wound care clinics. A lot of them are within the hospitals, right? They're typically run by a general surgeon. And the surgeon usually has a nurse practitioner, wound care nurses, in some cases, the physical therapist, right? There's not too many of us around that specialize in wound care, but we're there, right? And that whole team takes care of that wound. Okay, so that's your resource. That's who you go to. And if you have any doubts about that, that's who you go to, guys. That's who you go to. And as clinicians, right? Not everybody is a wound care expert. I totally get that, guys. I totally get that. Even as physical therapists, we receive wound care training in our schooling, in our grad school classes and everything that we take. But that doesn't mean that every physical therapist is a wound care expert. But at the very least, every physical therapist should be able to identify that's a non-healing wound and that person needs to go to a wound care clinic. And I will take it a step further. The prosthetist should as well. And I will take it even another step further. It is not up to the prosthetist to determine whether or not a person can walk on a wound. It's not. And in some cases, it's not even up to the physical therapist. It's up to the wound care team. And I know that's going to ruffle a lot of feathers, but that's the truth of it. And I'm going to speak the truth because it's my show. Okay. And guys, I have seen, and yes, let me backtrack because I know there's some people are going to say, well, I had a wound and the wound care team told me that I could use my prosthesis. Okay. First of all, if your wound care team cleared you to walk while you had a wound, that's good to go because that's your wound care team and they know what your wound looks like. They understand the pressures that are in that socket. That being said, I have very rarely seen someone with that kind of a wound being given permission to walk in a socket by their wound care team. Okay? Why is that? If you're in a socket that fits properly, that socket is fitting real snug. Okay? And in some cases, that could be compromising the circulation to that wound. And remember what I said earlier about the wound needing big, red, beefy granulation tissue? Think of ground chuck. You guys are just like, Cosi, you're so gross. I know, I am a little gross. Okay, but basically think of fresh ground chuck meat. That's what the wound should look like when it's healthy and it's getting ready to start budding in. It gets little buds and little epithelial skin cells and it starts being happy and growing in, right? It needs circulation to do that. So if you're putting a socket on it and you're putting pressure on and weight into that socket, you're impeding the circulation to that wound. And I don't care if you're healthy as a horse or if you have severe diabetes, you're impeding the circulation to that wound. So it's either going to delay the wound healing even further or it's going to cause even bigger complications. Okay? Now, when I had the case with this young woman on the phone, I said, look, until you get to your wound care team, don't wear your socket. Number one, it's causing you pain. So, it's pretty useless to wear a socket when you're in pain anyways. But number two, we need to keep that that pressure free. Okay, let me read some of these comments because you guys have been throwing some comments in there and I want to read some of these. So Tom says, I had an ulcer open up on my previous scare on my residual limb from an old break 4 days after wearing my first prosthetic. My team stopped me from wearing my prosthetic right away and it wouldn't heal up. Ended up having a revision because of it. But what was the first thing your team told you to do? Stop wearing your prosthesis. Stop wearing your prosthesis. And believe me, I've had lots of patients get real upset with me because in the old days when I worked in the hospital, they had a wound, I held on to their prosthesis. Okay. And David says, I'm going through wound care right now and I can't wear my prosthetic. Richard's like, yes, bless the wound care experts. Oh no, she was not that she was almost fit for a prosthetic, Teresa. She was fit for the prosthesis. And she had been trying to walk in it and was in a lot of pain. Yeah, no, I got off that phone call and my husband is like, what has got you so riled up? And I'm like, oh. And the thing is, guys, this is not the first case I've run into like this. And again, let me reiterate, I am not bashing prosthetists because I've seen PTs make the same mistake. And that makes me even more mad when I see a PT. In this particular scenario, the physical therapist made the right call. She reached out to someone who had experience in this area because she didn't know what to do, but she knew that something had to be done right away. Okay. And the prosthetist in this particular situation did not act appropriately. Okay. And the thing is now, the fact that they cast a socket on a limb that has a wound on it, right? So that means that area is even more inflamed because it has a wound sitting on it. So once that wound heals, she's going to have another socket made, right? She's going to have another socket made because that socket is not going to fit her once all that swelling goes down anyways from that wound. So, Brian says, when I see this on Facebook, I get so concerned of the advice I hear from people. No. And it's one of those things where, again, I look like a Monday morning quarterback yelling at my computer screen going, go to your wound care clinic. Do not put that stuff on your wound. Oh my goodness, right? And I'm sitting there going, huh, right? It's actually one of the big reasons I started this show, guys, because I started seeing stuff like that, right? Yeah, so zero form, there's a lot of different dressings. I wouldn't use necessarily zero form on this particular wound. Again, I think she needs an enzymatic debriding agent. So whether it's something like Silvadene or some of the other things that they've come out with nowadays, something that could really eat through that tissue. Yeah, so Stephen says, I had an infection after my revision. It was opened up and packed with iodine gauze. Susan says, I got a wormhole. Yep. Brian says he's seen it a lot of times. Joan has seen it a lot of times. Ernest says, I've measured tunnels from the SI joint to the trochanters. Okay, and here's the thing, guys. Here's another one of those like dirty little things that we have to do in wound care. So when we see a tunneling wound, there's this long, it looks like a Q-tip. It looks like a very long Q-tip. And we have to measure and we have to stick the Q-tip in to see how deep it goes. And that's how we measure the progress, right? The less we have to stick that Q-tip in, that means that the wound is starting to heal from the inside out, which is what we want. Guys, these Q-tips are this long, and there have been times where I've stuck the entire Q-tip into someone's tissue with a tunnel, and it sounds like Ernest did the same thing. Yeah, some of these wounds get really interesting. But at the same time, it's just like, as a therapist, those of us who like wound care, for us, it's like the most satisfying thing to see when those wounds start to heal in. And it's amazing when they do. So Marianne says, in February of 2021, her blister turned into osteomyelitis. Yeah, and guys, I've done a lot of shows on skincare, protecting skincare, many things like that. This one is a little bit more intense. Yeah, so Scott says many times, Hope says frequently. And Ryan says, what kills me is all the people who chime in and give advice other than go see your doctor. And guys, for me, I'm just like, I know it's coming from a good place, especially in the support groups where people are asking questions because they don't know where to go. Right. So I don't get mad about them asking the questions. I get mad about like, right. Because that's not what they're supposed to be doing. But I get it. Some people don't have the resources. Some people are not being guided properly as to where they should go. And the people on the Facebook groups who are trying to help them, they're really trying to help them from a good place. But unfortunately, not always the right advice. Not always the right advice. Right. Yeah, so David said, I had one-time tunnels that were 7 to 8 centimeters deep. Patricia says, see pictures like this all the time on Facebook, right? Similar things. So a lot of you guys are seeing this thing. David says, aiming for a great wound care specialist, had a great one. So sorry this person necessarily went through this. This was bad. Even my 5th grade brain figured out this person needed a serious wound care intervention. I know, right? It kills me. Oh, I've seen worse people. I've seen worse with people walking on it. And I'm just like, oh, dear heavens. Oh, dear heavens. Right. And again, I've seen some PTs screw up like this too, not just the prosthetists. So let me just preface that. Yeah, it's one of those. Yeah, all you guys are right on the spot right there. Kate says, ruffle away. Yeah, I know I'm ruffling some feathers tonight, but I'm going to go ahead and ruffle. Let's go. So Susan says, I had to wait 9 months before my wound care specialist would allow me to wear my socket. Hey, harsh. So yeah, and guys, again, I get it because I see the frustration in the past with my patients who had these wounds and they're just sitting there going, because we were, progressing with the therapy and a wound occurred, and it wasn't anybody's fault. It's just the wound happened and it prevented them from being able to progress with their prosthesis. And it's an incredibly frustrating situation. But yeah, I honestly, and if any of my clinicians want to chime in, I honestly really can't think of a case where I had a person with a wound, a non-healing ulcer, like the one that I just showed, that I would have said, no, go ahead and wear your prosthesis. Like, I just don't see that scenario in my brain. Oh yeah. Yeah. Not only that they could go wear their prosthesis, but that they could, just put some Neosporin on it. Yeah. I'm just gonna leave it there. Hey, compadre, comadre, thank you for being there. And guys, it's a why would they, and again, clinicians like this, now that I've spouted and then exploded and had my soapbox moment, I'm gonna reel it in just a little bit and say, this is the small percentage. Okay. In every profession, you're going to have the one bad apple of the bunch, whether you're an accountant, a lawyer, a doctor, a PT, a prosthetist, right? And unfortunately, it's the one bad apple that we all hear about, right? And talk about. So 99% of the prosthetists that I work with would have seen this wound and would have said, this person needs to go see a wound care specialist. Here's the number of the one that we work with. Go. And then come back to us when that wound is nice and closed and healed. 99% of prosthetists would have said that. Okay. This is just the 1%. And this is the 1% that we need to be aware of because it does happen. Okay. Yes, the Dakin solution. And I'm thinking for this particular individual, the Dakin solution mixed in with a little bit of enzymatic debridement with a wet to dry dressing and then good old mechanical debridement afterwards. And that's going to clean that thing up real nice. Yeah, Julie, yeah. Sorry, I keep pressing all the wrong buttons. Tom says, I had a wormhole after my revision and remembering to stick a Q-tip in. Oh, yeah. Yeah. And it was interesting, guys. So this is just like so one of the first, I started volunteering in physical therapy clinics when I was 16 years old. I started volunteering in hospitals when I was 14. And by 16, I was like, physical therapy is what it is for me. So I go into this first clinic and I didn't know that physical therapists did wound care. I had no idea. And the senior PT looks at me and goes, hey, rookie, come over here. Right. And I'm 16 years old, guys. This would never happen nowadays. And he had a woman that he was, treating in the thigh. And I see him just stick his entire hand into the side of her thigh, into that wound. And I just thought to myself, okay, so this is what I'm getting myself into with this career. Game on. Let's go. But yeah, it's going to be pretty intense. So Justine, I'll put the picture up in a little bit. So what they had the person put on the wound was Neosporin. Yeah. So guys, I'm giving you the second warning now because I'm going to post another picture. So this picture is just about a week and a half later. So I had this conversation with this particular young therapist, and she arranged for a wound care clinic appointment for her patient. And in the meantime, she got some recommendations from the wound care clinic, and they said, okay, while you're waiting, because it's about 7 to 10 days, while she's waiting to come and see us, these are some over-the-counter things that you can do for her and start getting that wound going, right? So I'm going to share a picture with you of this wound 10 days later after the young therapist has started just very basic wound care treatment, okay? So guys, I'm posting a picture now. So those of you who do not want to see a picture, exit stage left for just a minute. Okay, here we go. Okay. So check it out, guys. Here's a couple of things I want you to notice. Around the edges of the wound right here, a lot less red. It's still, kind of macerated. It's still kind of inflamed and not too happy looking, but it's a lot less red than what it was just even 10 days ago. Right here in this area, all that yucky tissue has started to fall off, and you can see that it's all nice and healed right here. This has turned into yellow slough, okay? So that means that that black necrotic tissue has started to soften up. And if you can see closely right here, this little dot right here, this little dot of red right there, that's the beginning of the bottom of that wound bed. So that's that little redness that we want to see. So this means that all of this is starting to soften up, and you can tell that the therapist has been going around the edges of the wound and breaking it off the edge of the wound, which is what she should be doing, okay? So it's still a pretty intense looking wound. It's still a wound, and it still needs to have a lot of management done for it, but you can see there's a change just with even 10 days, guys. 10 days of very basic wound care application done by the physical therapist. Right? So you can start to see that the edges of the wound, they have just a tiny little edge around to show that she was able to get that stuff to unstick, right? So when you can get all that junk to unstick, then all that stuff can start to heal in. And you could see at the edges, there's the wound bed right there. And that's what we want to see. We want to get down to that wound bed to get to that red beefy tissue so that it can start healing from the inside out, right? Yeah, Marion says it makes me go back through all the crap I went through. And again, I apologize, guys, if this is a trigger for some of you. That's why I kind of put all the disclaimers and all the warnings ahead of time, because I know that this is intense stuff, and many of you went through this. Richard says, I can talk about diabetic foot ulcers for hours now. Did not know when it first happened. No. Did I say anything? I did say something. I don't know if you guys could hear me. So Nalitza asks, if you see something red on your limb, should you stop wearing your prosthesis? That's a very, very good question, okay? So when it comes to redness on the limb, okay, there are certain parts of redness that are acceptable, or not redness, pink, okay? Other parts that are not. And in my first visits with my patients, my new patients wearing a prosthesis for the first time, I go over this with them, okay? So if you're a below the knee amputee, okay, you might see some pinkness down your shin bone, down the tibia. You might see some pinkness right underneath your kneecap at that patellar tendon. Those are the kind of pinkness that you're just looking at it going, okay, is it going to fade away and the skin is just getting used to wearing the prosthesis, wearing the pressures, or is that redness staying and it's not going away? Right? So that's something that you need to work very closely with your prosthetist and your physical therapist so that they can tell you this pinkness and redness is normal and expected when you're starting to wear a prosthetic device and your skin is getting used to it versus no, we don't want to see redness here, or we don't want to see redness that's not subsiding after you take off everything. Right? A lot of people have very delicate skin or very, very fair, especially my fair folks. They have very fair skin that'll light up with anything. Okay. So if I have someone who has very fair skin and their skin just explodes in pink whenever they wear their prosthesis, the first thing I say is, okay, when I take everything off, does that pinkness subside? If that pinkness is gone within a minute or two, then it's just like, okay, we just need to ease into that wearing schedule and do very carefully and very conservatively so that we don't open up something. My rule of thumb, Nalitza, and again, everybody's a little bit different, but my rule of thumb is if you have a blister, okay, then that's your clue that something ain't right, okay? Whether it's because you have friction going on in the liner and that liner's not fitting properly, whether it's because you have a pressure point somewhere in that socket and you need to talk to someone about that. But a blister indicates that there is irritation, that there's friction, that there are shearing forces going on within that socket. And that's the red flag right there, because you don't want that blister turning into something a whole lot worse, okay? Do blisters happen? Yes, blisters happen, okay? But the point is, fix it, find the reason why it happened, and fix that, okay? So again, redness is something that is a little, you got to figure out where's the redness coming from, okay? Now, if I see streaky, if I see rashes, if I see pain, if I see open wounds, yeah, that's a thing to stop wearing the prosthesis and figure out what's going on. Ultimately, and the more experienced you become as an amputee wearing a prosthesis, you're going to learn this, okay? But those of you who are new to being an amputee, definitely whenever you see something new on your skin that you've never seen before, yes, give your neighborhood-friendly PT or prosthetist a call and say, hey, this is what I saw. Can I send you a picture and you let me know if this is something I need to worry about or not? Okay, there are many of my patients, and I've had some folks who have been amputees for years, and they come work with me, and something pops up on their skin, and I'm just sitting there going, "What is that?" And they're like, "Nope, I got it. I got an antifungal. I already know what that is. I'm going to treat it. We're good, right?" And that's how it should be. You should know your body better than your clinician with time going on. Okay. Justine says, and Justine is a physical therapist, guys. I've never had someone with a wound wear their prosthesis because I am someone who tends to err on the side of caution. If I wouldn't do it, why would I make my patients do it? Ding, guys. And it goes back, you don't have to be a certified clinician to understand the concept of circulation, right? If there's no circulation going to that wound because you're putting pressure on it with a prosthesis, then that wound can't heal. Okay? So, and again, I'm going to repeat this part of it. The only person who should be telling you whether you should or should not wear a prosthesis with a wound is the wound care specialist. Okay? And I can almost bet my next year's salary, whatever that might be, that they're going to tell you not to wear it. They're going to tell you not to wear it. Chuck is asking, is it normal to need a referral from a primary care for wound care at a wound clinic? Yes. And depending on your insurance, guys, many of you might have to go through your primary care doctor to get that referral to the wound care clinic. Some people I know can just do a direct appointment. But again, if you're running into problems, guys, with your doctor, and again, guys, most of the time, doctors are good eggs, right? They're there to help you. That's the majority of them, right? So if you show them, I got this wound, and here's the words to use: non-healing ulcer. Bing! That's the red flag for us clinicians. Non-healing ulcer, right? And you say, can I go please have a referral to a wound care specialist? They're going to give it to you. Again, don't know what happened in the case of this particular patient. Okay. But thankfully she got it fixed. Hey, Jeannie, thanks for joining in. I haven't seen you in a while. Let's see. Susan says, I've had wound care so many times, I could be a wound care assistant. Yeah. Blister to blood blister ulcer in 3 days. Yeah. Hope says, I was never offered wound care, just another amputation. And again, guys, I don't know the nature of your particular case, Hope, but there are some cases where perhaps, there's an infection or too much gangrene going on, too much necrotic tissue, and the only solution is, a revision or an amputation. That's how many of you, I think many of you, especially if you're diabetic with vascular disease, how many of you probably ended up with your amputation is it started with a wound that wasn't healing. Yeah. Sean says, very difficult to see on someone who's African-American. Yes and no, because obviously the skin is darker, but you can see changes in the skin. You can see changes in the skin. And again, a person is going to know their own body better. So they're going to look at their skin and go, that's changing color right there. That's not the same color it was. So no, there is a way also to distinguish with African-American skin as well. Yes. Susan says, I was told if the red pink doesn't go away within 10 minutes, then something needs to be adjusted. Yep. Some people use 5 minutes, some people use 10 minutes. And again, as a clinician, you just go, especially if you've been working in the field long enough, you go, that's taking a little too long to reside. That pinkness to reside, we need to get something tweaked in that socket somewhere. Okay, so Susan says, got the new temp socket and it fits perfectly. Yay. Yay. Good for you. Oh, my pleasure, Nelitza. All right. Yeah, a bad fitting socket, it causes a lot of problems. Trey says, every issue I've had, Trey, holy smokes, man, I haven't seen you in a while. Good to have you, man. Every issue I've had in 13 years, I assumed it was too much pressure, mostly from the lack of contact on the distal end. Yeah. Yeah. So guys, it starts, and again, does go back with the socket. Obviously, this particular issue was not caused by a socket. It was caused because the person's wound dehisced, and I don't know if it's because she fell or whatever, but it just pulled open shortly after surgery, and it never had the chance to heal. David says, I have a strange one for you. No one has an answer. Oh, dear. When I shower, the part of my leg covered by my liner turns red, and the whole area, perfect liner on the leg at the top of the liner. It goes away after 30 minutes or so. No problems when leg or shrinker is on. It almost sounds like a little bit of a sensitivity reaction, like when the water hits it, especially if it's warm water, it just starts a sensitivity reaction. That is a good one, David. I don't have an answer for you on that one either. Let's see. Temperature regulation. That's a good. Oh, yeah, that's actually a really good idea, Justine. All right. So guys, I have piped off a lot this evening, and I thank you guys for letting me pipe off. Actually, while I have you guys on board, this is a shameful plug, but I got to put a little bit of a shameful plug on each one of my episodes. So hang on. Bear with me, guys. Bear with me. 721-0837. Okay. Those of you who are here, if you are not already on my texting service, text COSITALKS to this number. And guys, it would make me so happy when I close the show tonight and I check my texting to see some new subscribers. It's a really becoming one of my favorite ways to communicate with you guys because it's obviously through text. And here's the thing, you guys can text me back. Okay, don't forget, you guys can text me back. So if you want to text me your direction, your questions, you can do it on that texting service right there. Okay. Next week, guys, here's another thing I want you to do. Next week, put it on your phones right now. Next week, I am doing a show with Reggie Showers, who's just like one of my favorite all-time guests. And you're my other favorite all-time guest too, Zach. So between Zach and Reggie, it's a toss-up, right? Reggie is coming to Tampa, Florida. So it's going to be a good show, right? And we're going to be broadcasting out of Lululemon. Guys, we have some really nice giveaways. Lululemon is giving some nice stuff away on my show. If that does not catch your attention, ladies, let me repeat that. Lululemon will be providing me with some giveaways on next week's show. Gentlemen, you want this for your ladies as well, okay? And guys, Lululemon has great stuff for men too, don't get me wrong. Now, the show will be at 11 a.m. Excuse me. So guys, set your alarms on your phone. The show will be at 11 a.m. Eastern Standard Time. Okay, so it's not going to be at 8:30 p.m. It's going to be at 11 a.m. Eastern Standard Time next Wednesday. Okay, I already sent out to my email subscribers. Yes, and it's good free stuff. And College Park is giving away some of their rebuilt shirts, which are really, really nice. So, okay, yeah, have I got your attention? I got your attention. Okay, so next week, 11 a.m. Eastern Standard Time, okay? On my Facebook page, on my YouTube page, it's gonna be Reggie and I, and we're gonna be talking about how to choose a prosthetic foot, which is probably one of my favorite shows to do. I did this show with Reggie, it's gonna be almost 5 years ago, and we're updating the show, okay? So guys, this is a great show. We're going to talk about all the different classifications of prosthetic feet. What does it mean? How you should pick one out for yourself. Reggie's going to be there, so he's a wealth of knowledge right there. Awesome guy too, and lots of good free giveaways. So 11 a.m. next Wednesday. Yes? Okay. 7 a.m. in Alaska. I know. Yes, Kay. I appreciate you, and I love you, girl, for coming. Bring your coffee, and you'll really have an excuse to have a coffee cup there. Kay, you have one of the COSITALKS mugs, guys. If you're looking for Christmas presents, we got Cosi. I know this is so shameless right now of me. The COSITALKS exercise book for above the knee and below the knee amputees, and the COSITALKS mugs, in case you're looking for Christmas ideas. All right, guys, that's enough for me right now. I will see you guys next week. Not the same bat time, but the same bat channel.